Hello, Assalamu alaikum, everybody. Um, Please kindly let me know if my voice is audible or not, because sometimes it's like कि, आवाज आ रही होती है, but when you're going online on live, you're unable to listen to yourself. Oh,
Yeah, walaikum salam.
Assalamu
Yeah, it's very much fine. So I can hear you very well.
alaikum. Yeah, I'm just waiting कि कुछ बता दें हमारे audience में से भी if they can hear me or not. Okay, Maria at the Sham just replied, Walaikum Assalam. That probably means that she can hear us. Anyway, let's before starting the fourth live session, let me just tell you about the brief introduction about holistic. What holistic actually is. So it's basically a platform on which you can get the services of a physical therapist, an occupational therapist, and speech and language pathologist as well. Other than that, there are going to be some physicians and other practitioners available on the platform that will help you with your condition. And other than that, this holistic is actually being incubated in the National Incubation Center. And the founders and co founders of Holistic are all the students of Khyber Medical University. Now, आज जो हमारे साथ मौजूद हैं, his name is Mr. Shad Muhammad, and he is basically an orthotist. अब उनकी जो introduction है वो मेरे लिए भी बहुत ज़्यादा because he is very experienced. He has an experience in Peshawar, in a very renowned institute, PPOS, and then he has an experience. He had an experience in Afghanistan, in which where he worked with the Red Cross for 2 years, and then he came back to Peshawar and worked for a couple of years there, and then he moved to the UAE, United Arab Emirates, and there he has been working for 20 years. So that is a huge experience. Other than that, he runs his own pediatric orthotic facility in Dubai, and he also owns a shoe company in Sharjah. The shoe company actually manufactures the medical shoes for adults and children both. Um, and then, other than that, he teaches at the University of Sharjah, and he teaches the students of physical therapy and occupational therapy. And he also teaches at the Gulf Medical University to final year students of physical therapy. And he has had an experience of 15 years there. And he has been going to different organizations and been giving presentations, and he has been taking participation in innovation events and etc etc etc. So today we have a very experienced orthotist here with us, and assalamu alaikum.
Walaikum salam.
Sir, आज जो है we are going to ask you about the pediatric deformities and orthoses specifically. So please kindly आप हमें बताएं कि tell us about some common pediatric deformities and the orthoses used for them.
Okay. Bismillahirrahmanirrahim. Assalamu alaikum. Thank you, all viewers and all the people who are involved in this arrangement. Orthotics is basically a very vast field, and it relates to physical deformation. And as we are talking about children, so we have plenty of problem in children. Some of them they are congenital, and some of them they are acquired. So if we let's say if we talk about some congenital problem, for example, we have club feet in children, we have spina bifida, we have Erb's palsy, we have tiptoe walking, we have other spinal conditions. So then we have acquired problem like flat feet in children, like scoliosis in children, like any other gait deviation in children, valgus knees, varus knees, in-toeing gait of children, tiptoe of children. So then these deformation, when as the children grow, so they get more worse, and then eventually they can affect their lifestyle and their walking pattern, and in fact medical health. So what we do through orthotics to contain these problems so they will not grow and children they can live their normal lives. Oh, I can't hear you anymore. No, I lost you, I believe. I can't hear you.
Oh, I'm sorry. Can you hear me now?
Yes.
Uh-huh. Anyway, so I was asking if you also get involved in making orthosis for adults as well, or are you just specialized in doing making orthosis for pediatrics?
Being an orthotist, I do make orthosis for adult and children, but we focus more on children because of different reasons. But of course, I get a lot of scoliotic cases. We get some polio cases because polio is almost uh, out from UAE, and we get a lot of cerebral palsy cases. So you know that cerebral palsy children they have walking difficulties, they have balance difficulties, and they have deformations. So we try to contain their deformations and we make them walk so they can be mobilized and eventually they can live their life. So yes, I do treat adults as well as children, and then nevertheless also I treat with the different orthopedic surgeons, neurosurgeons, a different type of traumatic conditions and other sports injuries too.
Okay, so and what is the need for evaluation, like especially for the pediatrics, because they are growing, and their bones and their structures, everything is growing with the passage of time. So, what is the need for evaluation once you're done making the orthosis?
Screening is extremely important in most children because parents don't know exactly about their children if they have any sort of physical deformation until and unless children complain by themselves. So it is very important that children, whether they are examined by a pediatrician, a physical therapist, an orthotist, or even occupational therapist, so they can check their spinal alignment, they can check their knee alignment, feet alignment, overall structure. They can see if they feel there is any sort of alignment issue, any progressing deformation is there, then you can refer the child to the right person, the right profession. So screening and initial assessment that is extremely important to control the condition and to improve it gradually.
Gradually. Okay, and also, what is the need for re-evaluation, and how, when do you re-evaluate? मतलब after how long, आप कितने अरसे बाद एक patient को फिर से re-evaluation के लिए बुलाते हैं, especially the pediatric ones because they grow, तो फिर obviously when they're growing, their size changes, and then you have to make new ones. So, what is the duration for the re-evaluation?
जी, तो जो री एवेल्युएशन है वो केस टू केस डिपेंड करता है. For example, if there is a scoliotic case, we may re-evaluate after 6 months' time. If
Oh,
there is a infant, for example, clubfoot, maybe we can, for re-evaluation, we can ask him to come in 2 weeks' time. So children, they are like the age of till 12 years. We need very frequent evaluation depending upon the condition, severity of deformity, and the approach which you adopted for the treatment.
okay. So now that you mentioned clubfoot, it was something that interested me the most when I visited PPAS. I'm basically a student of physical therapy. I'm almost done with my degree. It's just stuck because of the pandemic. Um, when we went to PPAS, we visited the institute. The most important, the most interesting thing that I found was clubfoot, and they were treating it with some Ponseti method, I believe. So can you just shed some light on that for the audience?
Yeah, well, that is the best approach considered till now, the Ponseti one. It is a series of plaster where we make the joint of the feet softer and we get more correction, and then gradually and frequently we change the plaster cast, and we replace it with a new cast. So we correct the clubfoot gradually, and normally the child is able to stand like the age, like 8 9 months, like a normal child. Once the child goes through this process, sometimes the child need some surgical intervention because Ponseti cannot solve all the problem of the clubfoot. So then you have to go through some surgical intervention, and then again you go to the plaster cast and some very effective splinting. So that again depends from case to case how severe the deformity is and how we should adopt our approach. So clubfoot is a very disabling deformity, and it is a very complex deformity, and that need that we involve too many professionals like physical therapists, orthotists, orthopedic surgeons, and the specialist who will apply the plaster cast for Ponseti procedure. So that is extremely important. Yes.
Sir, now that you have told us about the Ponseti method and the clubfoot deformity, sir, let us know, is there a difference between the patients and their families in the UAE and in Pakistan? Are they more cooperative there? How is it? Is it any different?
Well, being a professional, it is more our responsibility to teach the parents before we start the procedure. It is our responsibility to explain everything to the parents before we start procedure, so they know step by step. Now, unfortunately, sometimes the parents are not very well educated. They may not pick things in the way you explain. So, of course, there is sometimes a challenge in Pakistan, but I think professionals, which I always insist, they need to be more patient, they need to be more cooperative, they need to be more sympathetic. Then I have seen very positive response from the parents. And in UAE, most families they are educated, and being a very central part of the world, so parents are normally more aware of different devices, and finance is not that big issue like in Pakistan. So overall, it is more easier to work with patients and families in UAE than Pakistan. But I think things are changing, and more professionals are getting more flexible and they're more cooperative.
uh, Whenever you are evaluating as an orthotist, whether it's a prosthesis or an orthosis, any device, what is more important, the static evaluation or the dynamic one?
Okay, I will put it in other way this question. I do understand what you want to say, but basically, every deformation, every dysfunction in the patient that has biomechanical requirements, that what the patient exactly need. So from our point of view, that is more important. So the patient may need very static AFO, and the patient may need a dynamic AFO. So we cannot recommend that, but we recommend that on the basis of assessment and evaluation, and most importantly, the biomechanical requirements. For example, a person has a weak quadriceps and he cannot extend his knee in the stance swing phase. So we need to give him an orthosis which can help him to keep the knee extended in the swing and stance phase. So that is his biomechanical requirement. That can be a static, that can be a dynamic. So it is from case to case.
ओके सर प्लीज़ काइंडली, क्योंकि हमारी और ऑडियंस को इतना कोई आइडिया नहीं है अबाउट एच के एफ ओज एंड के एफ ओज एंड काइंडली टेल अस अबाउट द लोअर लिम्ब orthosis. Is there, I think, very important?
Yes, low limb is basically called the limb of stability, and that is more important because we walk on the lower limb. So there are a variety of orthoses for the lower limb, and the most common device is used the ankle foot orthosis, which can be static, which can be dynamic, which can be for positioning purposes, which can be for walking, running purposes, for correction purposes, for fixation purposes. So that is the most common device which is used. And then normally HK4 is not wanted in cerebral palsy cases, even if there's a knee problem. We try to control things below the knee. But yes, if there's a paralytic condition like a polio, etc., or any other condition, then we have to go above the knee so we can control, we can basically stabilize the knee so the patient can put weight appropriately and he can walk properly. So that is the function of the care.
Okay. And what about the orthosis for the trunk? For example, for scoliosis or kyphosis. आजकल तो
Well,
खैर every other person is kyphotic because of the mobile usage and laptop usage.
yeah,
But I'm talking about
that's unfortunate that a lot of people they have postural issues and
yes.
they lose their alignment of the body and that does not look any more pretty and beautiful. So
Yes.
we have to take care of our posture. And in case if there is some fixed deformation in the back, which can be kyphosis, which can be scoliosis, then again, if it is they are pediatric, it can be controlled in the early stages, and you may not face too many miseries. But if the structure become mature and fixed, then the patient may have troubles. Even the person who treat the patient also have difficulties. So it is highly recommended that you, if you diagnose children with any spinal deformation, that you refer them to the right person.
If a person has scoliosis, he also has to go through surgery. लेकिन अब इसका क्या डिग्री है, कितनी डिग्रीज तक अगर आपकी स्कोलियोसिस है तो दैट कुड बी फिक्स्ड विद ऑर्थोसिस, या किससे ज़्यादा अगर एक्सीड कर जाएगी तो यू वुड नीड अ सर्जरी.
जी बिल्कुल, अगर आप कॉब्स एंगल की बात करती हैं तो कॉब्स में अगर आप समटाइम 20-25 तक भी अगर स्कोलियोसिस फ्लेक्सिबल है, वी ऑलवेज करेक्ट थ्रू एक्सरसाइज एंड ब्रेसेस. समटाइम इफ देयर इज अ वेरी इफ देयर इज अ सिंगल कर्व, अगर डबल कर्व है तो उसमें फिर पेल्विक ऑब्लिक्विटीज आती हैं, लेग लेंथ की इश्यूज आती हैं उसमें. तो अगेन वो डिपेंड करता है कि अगर बहुत ज़्यादा मिजरीज हो गई हैं स्क्लेरोसिस की वजह से तो हम ऑब्वियसली उसको ब्रेस करते हैं. लेकिन अगर स्क्लेरोसिस सिर्फ लिमिटेड है बैक में, बाकी उसकी कुछ एसोसिएटेड प्रॉब्लम नहीं है, तो फिर हम उसको छोड़ते हैं, उसकी एक्सरसाइज करवाते हैं फिजियोथेरापिस्ट के थ्रू, उसको हम ब्रेस पहनाते हैं दिन के वक्त, ताकि उसकी थोड़ी सी कंटेनमेंट हो जाए. तो करेक्शन के लिए पहले कंटेनमेंट ज़रूरी है, उसके बाद फिर आप ग्रेजुअली उसको करेक्ट करते हैं. और फिर आप उसको, जैसे मैंने पहले आपसे कहा, कि उसकी री इवेल्यूएशन करते हैं कि फिर उसको ज़रूरत है या नहीं है. तो कॉब्स जो है ना, अगर वो 30 से ऊपर है, 35 से ऊपर है और वो फिक्स्ड है, तो ऑफ कोर्स देन यू हैव टू लुक फॉर सम सर्जिकल सॉल्यूशन.
Um, okay, going towards pediatrics again. So, what is, can you tell us about some common deformities in the pediatric population that need orthotic treatment?
Uh, the most common problem in children is flat feet. So when they have no arches in the feet, then they can have easily knock knees, and then when they have knock knees, they can have humpback. So to avoid all these complications, it is important that the children they use proper shoes, proper arches. They become more stable. They will not get fatigue, and they are more aligned. So the second is that in children we have a lot of knock knees and tiptoeing. So tiptoe is also habitual because sometimes a parent they use the walkers prematurely for children. Uh, तो बच्चे टिप टॉप पे चलते हैं क्योंकि उनकी जो प्लांटर फ्लैक्सर्स हैं दे डेवलप मोर देन डॉर्सिफ्लैक्सर्स. और उसके अलावा जो बच्चों में जो कॉमन इश्यूज हैं वो आपके इनटोइंग है. तो काफ़ी जो बच्चे हैं वो अपने पैर अंदर की तरफ लाते हैं, तो उससे भी उनके जो बैलेंस है वो ख़राब होता है. उसके लिए भी स्पेशल शूज़ अवेलेबल हैं और बाकी टॉर्जन केबल्स वगैरह हैं, तो वो स्पेशलिस्ट को दिखाना बहुत ज़रूरी है. और बाकी बच्चों में जो है वो फिर स्कोलियोसिस है, अगर फुट में प्रॉब्लम है, नी में है या हिप में है, तो दैट हैज डायरेक्ट इम्पैक्ट ऑन द spine. So it is important that we keep legs safe and sound so there's no complication in the spine.
I think this is very informative for a lot of people. For all those patients out there, for all those parents out there जो अपने बच्चों को आगे भेजना चाहते हैं in army or something, most common जो problem होता है जिसकी वजह से the students get rejected is flat feet and that according with, as you just told us कि इससे knock knees होती हैं and tiptoes and all that. So for that you need to get your children evaluated by an orthotist and a physical therapist and get him treated as soon as possible. As सर ऑलरेडी टोल्ड कि जो है बच्चों में पीडियाट्रिक पॉपुलेशन में जो है इसको फिक्स करना इज़ वे मोर ईजियर. तो दिस इज समथिंग दैट everybody, all the audience here should know. Okay, coming towards the medical shoes, what are the common problems that you deal with, and what are the common problems जिसको आप जो है medical shoes से treat करते हो? I have been studying lately about plantar fasciitis. I think I think नहीं बल्कि I know even the solution to that, the number one solution to that is using proper shoes, and if it's already occurred, then you need medical shoes for its correct for its treatment. So, can you tell us more about the medical shoes and what
Mhm.
pathologies need the medical shoes, bunions, and all? आप जरा कुछ audience के लिए बता दें.
Well, feet are basically for people think it's for walking purposes, but basically a person can walk without feet. So feet are basically for balance purposes. You make yourself balance. So you will see amputees, they lose their feet, but they can still walk. सो फुट का जो रोल है वो आपकी पूरी बॉडी को फ्लेक्सिबल रखता है, बैलेंस रखता है, सो यू कैन परफॉर्म डिफरेंट जॉब्स एंड फंक्शंस. अगर फुट में स्टिफनेस है देन यू कांट वॉक फॉर लॉन्ग टाइम. अगर फुट में पेन है अगेन यू कांट वॉक फॉर लॉन्ग टाइम. तो फुट का जो स्ट्रक्चर है उसका नॉर्मल होना बहुत ज़रूरी है कि वेट वहाँ पर पड़े जहाँ पर वेट को आना चाहिए और वहाँ पर वेट ना पड़े जहाँ पर वेट को नहीं आना चाहिए. तो फॉर एग्जांपल अगर फ्लैट फीट हैं तो उसमें जो वेट डिस्ट्रीब्यूशन है दैट इज इम्प्रॉपर. उसका नुकसान क्या होता है कि यू गेट वेट ऑन द एरिया वेयर इट शुड नॉट कम. तो उससे आपके ब्लिस्टर आते हैं, आपके बोन शिफ्टिंग होती है, आपकी जॉइंट कोलैप्स होते हैं, आपको मोस्ट इंपॉर्टेंटली फटीग होती है, यू कांट वॉक फॉर लॉन्ग टाइम. एंड दैट इज द रीजन दे विल नॉट एक्सेप्ट यू इन द आर्मी बिकॉज यू हैव टू वॉक, यू हैव टू रन. सो फुट का जो स्ट्रक्चर है दैट हैज़ टू बी रीजनेबली ओके सो देन यू कैन लिव योर नॉर्मल लाइफ. तो उसके लिए ज़रूरी है कि आप डेली फुट को स्ट्रेच करें, फुट के मसल को आप स्ट्रेंथन करें, आप फुट के स्ट्रक्चर को मेंटेन करें. इन केस अगर फ्यूचर में आपको डायबिटीज़ हो, आपको आर्थराइटिस का प्रॉब्लम हो, तो आप उसको मैनेज कर सकते हैं. सो medical shoes has a very vast field, and basically medical shoes are those shoes which we modify and we alter for a specific medical or orthopedic condition. तो उसमें फ्लैट फीट भी आते हैं, उसमें डायबिटिक फीट भी आते हैं, उसमें एंटी एडक्टस फीट आते हैं, उसमें टिप टोज आते हैं, उसमें जो फुट के जो प्रोनेशन है, सुपिनेशन है, फुट की जो बैलेंस की इशू है, उन सबको हम शू के थ्रू फिट करते हैं. एंड मोस्ट इम्पोर्टेंटली हम नीज को भी शू के थ्रू ट्रीट करते हैं, क्योंकि जब फुट ख़राब होते हैं तो नॉर्मली नी में इशू होते हैं. तो हम शू को मॉडिफाई करके उसको अल्टर करके then we realign the knee joints and normally patients are very happy. So medical shoes in general, they are modified shoes for a specific medical and orthopedic condition, but in general people should use good quality shoes, leather shoes, thick sole shoes, strong shoes. ऐसा नहीं कि फैब्रिक वाले शूज़ और जो बड़े सॉफ्ट किस्म के होते हैं, लोग समझते हैं कि सॉफ्ट अच्छे होते हैं, बट बेसिकली दे डिफॉर्म योर फीट मोर. सो अच्छे शूज़ हमेशा महंगे होते हैं, बट देर every time they are good for your feet.
Okay. इसमें जो है the females out there जो heels पहन रही हैं ये उनके लिए भी स्पेशली है कि चलो ठीक है for some events you can wear heels, but
Heels,
in the long
okay,
run you'll be ruining your feet.
yeah, I mean, appropriate heel like a 3-4 centimeter is very much fine. It's good for the foot until and unless you have foot problem. तो जो 3-4 सेंटीमीटर का हील है दैट इज ओके फॉर एनीवन. लेकिन इफ़ यू नो नी प्रॉब्लम एंड फुट प्रॉब्लम, क्योंकि दूसरी बात है कि जो आपके हील्स हैं देयर हील इज़ इम्पोर्टेंट फॉर एवरीवन, व्हिच आई ऑलवेज से दैट हील इज़ लाइक योर पिलो. अभी हर एक आदमी को, हर एक इंसान को एक पिलो चाहिए ताकि आपके नेक की रीअलाइनमेंट हो. इस तरह हमें सबको, मेल है, फीमेल है, बच्चे हैं, उनको हील चाहिए. हील जो है बेसिकली इट रीअलाइन योर होल बॉडी. अगर आप बगैर हील की शूज इस्तेमाल करते हैं यू विल डैमेज योर फीट, यू विल डैमेज योर नीज, यू विल डैमेज योर बैक. तो ऑलवेज यूज शूज विद अ प्रॉपर हील व्हेन यू वॉक. But if you're just hopping inside your home, it's fine if you walk bare feet or the flat sole shoes. Otherwise, whenever you step out of your home, you must use shoes with proper heel.
बिल्कुल एंड व्हाट अबाउट दोज पीपल जिनकी ऑक्यूपेशन जो है इस टाइप की होती है दैट दे नीड टू स्टैंड for longer periods of time. For example, we have neurosurgeons, they stand for a very, very long time. We have athletes, we have so many other occupations, even teachers who stand for so much longer time. The 2 hours की class होती है, then they go to another class and then they spend time there and they're just standing on their feet all the time. So what do you suggest for such people? किस टाइप के उनको इंसोल्स या इंसर्ट्स अपने शू में डालने चाहिए बिकॉज दैट कुड एक्चुअली लीड टू फुट डिफॉर्मिटीज प्रॉब्लम्स एज वेल
Yeah, that is a very good question. I mean, मेरी क्लास 3 घंटे की होती है यूनिवर्सिटी में, so I can feel that which type of shoes you should use. Now we call them anti-static shoes, जो कि सर्जन यूज करते हैं ऑपरेशन थिएटर्स में. एंटी-स्टैटिक शूज ऐसे होते हैं कि उनके सोल बड़े थिक होते हैं, अंदर से सॉफ्ट होते हैं, बाहर से हार्ड होते हैं, ताकि आपका फुट स्टेबल रहे और मूव ना करे. तो anti-static shoes
ओके
they're ideal for doctors in the OTs or for anyone who is walking continuously in specific area, and they're very good. Otherwise, if you are a very normal person and you do some specific job, then I highly recommend that you should choose shoes with a thick sole. Thick sole का फायदा ये होता है कि आपका foot stiff रहता है. That means more stable, less flexible. You don't feel fatigued. But if you are like you want some kind of quick movement, then you need thin sole. Like as you said, जो running वाले लोग होते हैं, उनके शूज जो है ना बड़े पतले होते हैं, उनके thin sole होते हैं, because they need sprint and they need to move very quickly. तो उनको तो सोल का आपने बड़ा केयर करना है अपनी फीट के लिए कि आप किस टाइप का सोल चूज करती हैं और किस टाइप का हील चूज करती हैं. ऊपर जो शू का ग्रिप है वो बहुत जरूरी है कि वो फैब्रिक ना हो, वो लेदर का हो, तो वो सबसे बेहतर होता
ऑल्सो उनके लिए आई थिंक इंसोल्स होते हैं शॉक एब्जॉर्बिंग ताकि
है. जी,
इट्स मोर अप्रोप्रिएट फॉर देम
इंसोल जो है उसके दो फंक्शन हो सकते हैं, या तो वो रीअलाइनमेंट का काम करते हैं शू के अंदर इफ दे आर नीडेड, और कभी कभी वैसे भी हम कंफर्ट के लिए यूज करते हैं, सिलिकॉन के आते हैं, बाकी फॉर्म्स के आते हैं. अगर वर्स्ट केस में अगर फुट का प्रॉब्लम है तो हम कस्टमाइज बनाते हैं इंसोल, तो फिर शू के अंदर डालते हैं. उसका फायदा ये होता है कि एक तो जो डिफॉर्मेशन है उसमें प्रोग्रेशन नहीं होती, और दूसरा ये है कि ब्लिस्टर नहीं पड़ते, और तीसरा ये है कि अलाइनमेंट की वजह से आपकी नीज और बैक में प्रॉब्लम नहीं आती.
नीज एंड बैक में प्रॉब्लम आता है बिल्कुल
जी.
sir now tell us about some common walking problems in children
जो बच्चों में जो कॉमन जो वॉकिंग एबनॉर्मेलिटीज हैं, उस उनमें एक जो है वो टिप टो का है. टिप टो का मतलब है कि बच्चे जो है ना वो टोस के ऊपर चलते हैं, वो हील जमीन पे नहीं लगाते, तो उससे फुट डिफॉर्मेशन के बड़े चांसेस होते हैं, उससे नीज भी खराब होते हैं. तो ज़रूरी है कि हम उसको कंट्रोल करें थ्रू मेडिकल शूज़. समटाइम हम उसके लिए स्प्लिंट्स भी इस्तेमाल करते हैं, और कभी कभी हम फिर उसके लिए जो है ना वो इंजेक्शन यूज़ करते हैं बोटॉक्स का. तो वो डॉक्टर की उस पर डिपेंड करता है. डॉक्टर अगर सीवियर प्रॉब्लम है और टिप टो का जो लेवल है वो बहुत ज़्यादा है, then you have to consult an orthopedic surgeon, and he has to examine him, and he has to specify how much Botox dose the child needs. दूसरा जो कॉमन प्रॉब्लम है बच्चों में वो इंटोविंग है. इंटोविंग का आजकल है कि बच्चों के जो पैर है वो अंदर की तरफ आते हैं, उनका उससे बैलेंस खराब होते हैं, वो गिरते हैं, उनके फ्रैक्चर होते हैं. सो इट इफेक्ट देयर लाइफस्टाइल एंड दे कांट परफॉर्म इन स्पोर्ट्स इवन टू. तीसरा जो है बच्चों में ये होता है कि उनका जो स्टैंडिंग का पोस्चर होते हैं वो बड़े ख़राब होते हैं. दे डोंट स्टैंड ऑन बोथ लेग इक्वली, दे डोंट पुट वेट इक्वली ऑन बोथ लेग्स. तो ये बहुत ज़रूरी है कि आपके दोनों फीट बैलेंस और सरफेस पे लगे हैं, और आप 50% राइट 50% लेफ्ट साइड पे आप वेट लें. ये नहीं कि आपने एक पैर ऑफ किया हुआ है, दूसरे पे आप खड़ी हैं, तो फिर आपके स्पाइन में, आपके जॉइंट्स में, आपकी फीट में उसके प्रॉब्लम्स आ सकते हैं. और बाकी काफ़ी लोग जो हैं वो घरों के अंदर बच्चे भी वो नंगे पैर चलते हैं, तो कंटिन्यूसली नंगे पैर घर के अंदर चलना, दैट आल्सो डैमेज योर सॉफ्ट टिश्यूज, दैट कॉज अलाइनमेंट इश्यूज, एंड दैट कॉज फटीग. तो ज़रूरी है अगर आप पूरा दिन घर में हैं तो आप शूज़ भी इस्तेमाल करें, वो ज़रूरी है.
or at least some soft slippers अगर शूज नहीं भी पहन रहे हैं घर पे.
जी जी हाँ, कुछ भी मतलब कि देयर शुड बी समथिंग बिटवीन योर फुट एंड द फ्लोर.
Oh, okay. Sir, also, यहाँ पे there might be so many students who would know the difference between orthotic devices, orthoses, and prosthesis. But there might be a lot of other people who wouldn't know the difference between these two. Could you just enlighten them with the difference between these two and a little bit of information regarding
Yeah,
it?
well, I mean, it's a very basic question and I think important question. जो प्रोस्थेसिस हैं उसका ताल्लुक एम्पुटेशन से है. When there's amputation, then we replace the missing part of the body functionally and cosmetically. तो अगर किसी का लेट्स से एक अंगूठा जो है उसकी एम्पुटेशन है, कान की एम्पुटेशन है, नाक की है, पैरों की है, तो उस पार्ट को जब आप रिप्लेस करती हैं तो वो प्रोस्थेसिस है. लोग आंख लूज करते हैं वो भी प्रोस्थेसिस है, दांत लूज करते हैं वो भी प्रोस्थेसिस है, लेकिन बेसिकली वी आर टॉकिंग अबाउट लिम्स, अपर लिम्स एंड लोअर लिम्स. तो जो प्रोस्थेसिस है दैट इज अ डिवाइस व्हिच रिप्लेस द मिसिंग पार्ट ऑफ द बॉडी फंक्शनली एंड कॉस्मेटिकली. फंक्शनल या कॉस्मेटिकल इसलिए कहते हैं कि अगर लो लिम्ब है तो आदमी या बंदे ने चलना है तो वो फंक्शनल हो गया. अपर लिम्ब में कभी ऐसा होता है कि अपर लिम्ब से आप काम ज़्यादा नहीं कर सकते, जो आपके ट्रेडिशनल जो रिवायती किस्म के अपर प्रोस्थेसिस हैं अपर लिम्ब के, तो वो सिर्फ कॉस्मेटिक पर्पस के लिए होता है. तो लेकिन ऑर्थोसिस जो है दैट इज़ डिफरेंट बिकॉज ऑर्थोसिस में एम्पुटेशन नहीं होते. तो ऑर्थोसिस जो है ये वो डिवाइसेस हैं दे आर अप्लाइड एक्सटर्नली on the body for different purposes. But mainly, we say that the orthoses are devices which are used for rehabilitation purposes in skeleton deformations. अगर skeleton में किसी भी टाइप की deformations हैं तो उसके correction के लिए जो हम device इस्तेमाल करते हैं वो orthosis है. So that can be for a very like hammer toe, it can be for hallux valgus, it can be for scoliosis, it can be for fracture, it can be for torticollis, it can be for any other deformation in the structure of the body from head to toes. So we apply these devices and they are called orthoses.
Also, I've noticed when I went to PPOS, I noticed कि जितनी भी prosthesis थी वो mostly cosmetic purpose वाली थी. Say suppose you just mentioned कि functional lower limb जो होती है वो functional होती है तो हमें उसके लिए functional prosthesis चाहिए होती हैं. But what I saw there was that वहाँ पे सिर्फ और सिर्फ इस type की थी जो कि were only for cosmetic purpose and were not functional. So, what is the reason behind this? Why aren't people going for dynamic ones? Why aren't people going for the ones जिसमें कोई movement हो? Is it because of the money issue, financial issue, या क्या reason हो सकता है इसके पीछे?
PPOS is my parent organization and I love this organization and I frequently go there. I have good friends there and they're doing wonderful job and we always work together to improve the standards and their overall systems. Now, basically the devices when they are made as per the patient requirements, number one. Number two, they are also made looking into the affordability of the patient. Number three, they are also made looking into the area where the patient lives. So things which we see basically in the internet or maybe in Dubai or maybe in Texas, they may not be applicable in our part of the world because of different reasons. So dynamic splints, for example, are dynamic prostheses, as you said, they're more functional, they're robotic, they're high performance. तो अभी हमारे लोग जो है ना या हमारे जो इदारे हैं नंबर वन वो ये चीज़ें जो हैं अफोर्ड नहीं कर सकते, दे आर एक्सट्रीमली कॉस्टली. नंबर टू, हमारे लोगों का जो लिविंग है इट इज़ वेरी बेसिक लिविंग, इट्स नॉट वेरी हाई फाई लिविंग. नंबर थ्री, हमारे लोगों की जो एक्स्ट्रा करिकुलर एक्टिविटीज़ हैं वो बहुत कम हैं कि जी वो सी साइड पे चले गए कि वो जो माउंटेनियरिंग करते हैं वो और वो सहरा में दौड़ते हैं, वो ऐसा नहीं करते. तो उनके बड़े लिमिटेड एक्टिविटीज, तो उन चीज़ों के लिए बेसिकली आप जो एडवांस वर्जन के प्रोस्थेसिस है इवन ऑर्थोसिस हैं वो मुख्तलिफ रीज़न की वजह से आप उनको सप्लाई नहीं कर सकते. अदरवाइज पीपाज में बड़े अच्छे प्रोफेशनल हैं और वो सर्टनली दे कैन मेक, but I think maybe they do it for the betterment of the patients, whatever they need.
And within the affordability. of the
Yes,
bone.
that is very important. Yes.
Okay, I think we should go on and read some comments because there are people asking questions. I
Okay.
will just scroll up and I'll see if there's any question. Okay, Maria Atisham says, Walaikum salam. Nazi Subhan says, good to see you. Afaq Ahmed, Assalamu alaikum. Muhammad Siddiqui, or Siddiq, I don't know, says, well done and keep it up. And there are lots of other people saying, Assalamu alaikum and good job. Um, okay, I am trying to find a question. Okay, the first question is by Irfan Ahmed. His question is, what about the orthotics in cerebral palsy? Can you please make a light on it? Throw some light on it.
Cerebral palsy children, they're very tricky because there's no tone loss in those children. There's always additional tone. So you have to control the hypertonic muscle not to create problems. So there's always a challenge for the ankle foot area where the foot is going in plantar position, and that cause sometimes the knee, whether inflection or sometimes the knees also constantly in extension. So try to solve the cerebral palsy patient problems through ankle foot orthosis. Do not go above the knee because otherwise they will not walk. So for cerebral palsy patients, we are doing two main things. The articulated ankle foot orthosis, like you said, dynamic one, they are very effective if there is a plantar position on the foot. And if there's any knee issue, then we go for the floor reaction orthosis. These two below knee orthoses are extremely effective for children with the cerebral palsy. Yes, if there's a knee contracture or any other tightness, then you can go for a non-walking device. That means the child can use it while sleeping or while at home. But for walking purposes, for cerebral palsy children, high ankle boots, ankle foot orthosis with articulation, and floor reaction, they are the best devices to manage their mobility problems.
A question from me now. Are there canes needed in the beginning? Canes, the braces, sometimes the patients need for support.
Can you repeat your question, please?
In the beginning, to just get used to the orthosis, do some patients need canes or
Ah,
braces to
okay,
walk
okay.
for the gait? Yes,
Yeah, the mobility aids, yes, you're talking about the walking aids.
walking
Now,
aids,
for
exactly.
cerebral palsy, the best aid is normally the reverse walker. Reverse walker help cerebral palsy children to keep their knee and hip in maximum extension. And these walkers are available because they normally need, if they're bilateral spastic condition, then they need a reverse walker. But
Okay.
normally children, we don't recommend crutch or cane like age of 7, 8, 9 because it's not stable. There's chances of falling down and problems.
Okay, and okay, the next question is, let me put it to the screen as well. At what age orthosis should be prescribed for flat feet? That is a question by Zunaira Anwar.
Yeah, so it's a good question from Zunaira. Again, I will say that flat feet has 3 degrees, and there is a minor loss of arches. There's a medium loss of arches, and there's a severe splenovalgus condition where the bones are shifting their places and the joints are collapsed. This condition can also cause knock knees. So I think, in my opinion, there may not be a specific age, but there is certainly a specific condition. So when you see a patient, a child with the age of like 4 years, and you see just merely arches are collapsed, ask the children to go home, use good shoes, and come back like in 3 months' time or even 6 months' time. But if you see the child with a calcaneus deviation and that causes knock knees, you should give them medical shoes. But if you see a child with a severe pesprin valgus, you must give them customized insole or customized supramandibular orthosis with the shoes to control the deviation. So it is really very tough to say that from which day, from which age the child should use. But I will say rather that you should know the condition and severity of the problem in the foot, and then you decide accordingly.
Okay. There's another question. Please share some therapy of valgus. I think she's
Therapy,
trying to ask about some orthosis for valgus or
valgus foot.
therapy
Now,
of valgus.
yeah, valgus foot is the severe condition on the flat feet. We call it pes plane valgus. Now, pes plane valgus, where calcaneus is in valgus position and the medial arches are completely collapsed, then you will always see associated knock knees, and that cause difficulty for children. So first option is that you go for a typical medical shoes with a high ankle, stiff heel part, Thomas heel, medial arch with a medial wedge, and check that like maybe for 3 months and maybe for 6 months. If that is in control, otherwise then you make the child an SMO, which we call supramalleolar orthosis, that controls everything perfectly. And the advantage is that the child can use a supramalleolar orthosis in different shoes, so that make it more attractive for a child.
Okay, great. And there's another question. What kind of orthosis will you prefer for a child to prevent his external rotation in lower limb?
External rotation is normally done in Pesplen valgus condition if it is from the foot. But be careful that the external rotation can be from the hip also. So if there is an imbalance of musculature in the hip, then you have to go for something else like a torsion cables. But again, if the deviation is not threatening his life, the deviation is not disturbing his gait cycle, leave it under observation. Otherwise, to control the external rotation, you can go for medical shoes. We have special shoes, but don't give them any. It has to be the medial arches, because these children, when they lose the medial arches, the foot goes in abduction in eversion basically, and that cause rotational issues. So these children, when you again form their foot medial arc, the foot may come back to normal position. But you have to decide by yourself the rotation, whether it is in the foot area or it is in the limb area. If it is in the whole limb, it is from the hip. If it is in the foot, then you can control through the medial arches and medial wedges and the proper medical shoes.
Okay, great. Okay. Irfan Ahmed says thank you, sir. And then
Welcome.
there is Amna Rashid or Rashid, I don't know. She's asking, what can be the disadvantage or bad effects that patient have to face if we prescribe HKFOs?
Okay. Well, the first bad effect be, if it is not needed, you should not recommend.
Okay.
So what you recommend, what we call, yeah, so the recommendation strictly depend upon the biomechanical functions. So you know the patient deformations, muscular imbalance, joint deformities, and then the lack of biomechanical function. And then you come to conclusion that, well, I need to improve this medical biomechanical function through this device. So that means you need a proper knowledge of this device, which you can recommend. So HKF is a very big device, but of course we recommend in some polio cases where there's a ankle, knee, and hip instabilities, then we go for HKFOs. Even sometimes we go in spina bifida for HKFOs. We also go in some cerebral palsy cases for HKFO occasionally. So I think HKFO is a psychologically very big device, but end of the day, you have to justify it. If it is needed, you have to have it.
Yes, exactly. It's a little uncomfortable as compared to KFOs and AFOs. It might cause some irritation, skin irritation, and stuff. Oh, okay. Now I have another question. What if a patient has given some orthotic device, but he feels some irritation and he feels a little bit of issue in donning and doffing of the device?
I mentioned,
What do you do then?
I mentioned earlier that it is the responsibility of the professional to explain everything to the parents. how to put it on, how to put it off, for how long you have to use it. And if you initially you can come across with some problems, you have to solve like this. And later on, if you get more problems, you can contact me. So all these things are basically gradual, and you have to explain to the patient. That is the protocol which every professional must follow. Now, some patients they have allergy problem with the plastic, for example. So you can cover the plastic with the hypoallergenic layers, so no allergy problem. Sometimes the orthosis is not well fitted, it can cause pressure sores and discomfort. So you can check it and you can change it or you can alter it. So I think the person who delivered the orthosis, it is his responsibility to teach the father or mother or parents, both or some relatives, that these problems are can be expected, and at the moment we have no problem. But if you expect, for example, like this, like this, like this, don't worry. But if in case the redness is too much, it hurt malleolus or it put pressure on the patella, you contact me. Don't use it. So instruction need to be very clear, gradual, and I think it is one thing I will add that the problems are more with the walking devices like AFOs and TFOs. They are less with the non-walking device like hand splints, healer soles, neck collar, because you're not putting weight on those devices. So any device which is for walking purposes, you need to be extra careful. They need to be extra comfortable, and they need to be really made in a way that the pressure, the ground reaction forces are easily absorbed by the patient, and they don't cause any discomfort.
Yes, I might be wrong, but as far as I can remember, I think the redness should fade away by 10 minutes. And if exceeds 15 minutes or so, then it's, I think, something that you have to report. Am I right? Actually, I
Uh,
studied these in fifth semester, and it's been a long time, so it's a little hard for me to recall.
I think you're right to a certain extent because in walking device, basically, discomfort is not acceptable to anyone. So, but I think sometimes like a CP patient, it is you need to be more careful because they have loss of muscles and really everything is like you don't have flesh and it's very bony structure, so it can hurt the patient. But otherwise, in normal people, like somebody has some injury and you give AFO, it is very much okay. But polio and CP, you have to be extra careful.
Okay, great. And could you please tell the audience who is actually a part of the evaluation team, who actually diagnoses the problem and who makes the orthosis with the whole team? Can you just tell us about them? कि इसके अंदर कौन कौन होते हैं? Physical therapists are involved, occupational therapists are involved, surgeons. Just give a little bit of information regarding
Yes,
this.
it is basically like you're talking about a full team, like a multidisciplinary team.
Yes, exactly.
Yeah. So the in the team, of course, the patient normally go to the doctors first, and they check everything, medical point of view, physical point of view, and they check the muscular conditions, they check their joint conditions, and then they come, basically they recommend, for example, if there is some sort of physiotherapy need, they go to physical therapist. If they feel that no physiotherapy is needed, they can come to orthopedist and we can make orthosis. But at the end, there's a very close collaboration between the orthopedist and the physical therapist. And they should work, stick together. They have domains, but basically these domains are overlapping for the betterment of the patient. So normally it's never like this that a patient come to you and then you finish, then he comes to me. No. Maybe during the treatment, the patient need my device. So you will continue your physical therapy. At the same time, I can also apply him the splint. So physical therapist and occupational therapist and the orthopedist, they must work very close together, and they must accept each other, and they must know the domain of each other, and they also know the treatment uh, procedure of each other. Then the patient can get maximum benefits out of this.
Great. Okay, I just see two more questions.
Yeah.
अगर और भी किसी ने questions पूछने हैं तो please be a little quick because we're going to be ending the session in a while. Okay, now we have another question. Okay, what kind of shoe orthosis is used for pediatric burnout?
For pediatric
Burn patient. Burn
burn.
patient.
Okay, burn patient. Well, I think if let's say if sole is the sole is damaged, then you need a very customized insole or shoe inlay inside, which can realign the foot, which cannot put pressure on the burn point, and which can accommodate the foot very well. And the otherwise, if there is an injury to the joint, for example, on the dorsum of the foot, then you have very special shoes which are made of fabric and they are highly adjustable because these feet have also swelling issues which you can adjust so not to put excessive pressure on the skin either way
Mhm.
upward or downward and to accommodate any swelling any what you call the scars are very sensitive normally so these things need to be accommodated very nicely from either way and most importantly the shoe should be very much airy so there's no suffocation and no sweating.
What about if the burn is in the arm? Say, suppose in this area, in the
Uh,
arm involving some joint,
burn in which part of the body?
in the arm,
In the arm, and okay, upper limb.
upper
Well,
limb, exactly.
yeah, with in the arm normally when there's a burn, and there's chances of contracture in the elbow and wrist joint and fingers. Now we work very close with the occupational therapists in this regard, and we try to control the muscles not to cause any contracture which are existing. There are more chances of the elbow contracture, but for that we have static splint and we have dynamic splints. Static splint we use nighttime and dynamic splint we use for correction purposes. So we extend the elbow gradually. And even the
Oh,
patient can use it while he is during treatment. He can use the splint for different function purposes. The same for the upper limb, for the fingers. We have dynamic splint which can strengthen the muscles, which can mobilize the joint, which can reduce stress in the joint, which can reduce swelling. These are dynamic splint. Again, nighttime when the patient sleep, you can apply static splint to maintain the desired position of the patient.
okay, great. And okay, the last question from me. I don't think any other person is asking any questions. Can you just tell us a little bit about the orthosis related to the neck area, the cervical
Cervical
orthosis?
Yeah, cervical orthosis, they have a very vast variety, and it can be a simple high and low density foam for realignment purposes, for relief purposes, for muscular spasm. It can be like Philadelphia or Thompson splint for unloading purposes of the neck. There's a disc compression, disc herniation, disc prolapse in the cervical spine. If there is any fracture in the neck, then there's a halo braces which we apply. That means to unload the spine, the cervical spine completely. So then we have a very good device for the disc herniation, which we call the pneumatic neck collar. It is inflatable that take all the weight out of the neck, and the patient is very much relieved, and that helps in healing purposes too.
Okay. The pictures that I saw of those Halo one and the Milwaukee one, they were kind of very scary and not cosmetically.
In bed, yeah,
Uh,
they're normally used for the in bed patients, hospital patients,
in that.
but for the healing purposes and to prevent any sort of like paralysis in upper limb, it is important.
Exactly. Otherwise, they look really, really bad physically.
Yes.
Appearance mein dekha jaye to it's not that good. Are there going to be any modifications in the devices in the future? Are we expecting any modifications so that
Yes.
they're made a little more comfortable and a little more pleasing?
You see, the most beautiful dresses are the most expensive one, correct?
Yes, exactly.
So
Okay,
when you make
I
it, when you make the devices more beautiful, that means they're modular, they're adjustable, they're more acceptable, they are colorful, they are very costly. So what
They're
you
very
see there with the minimum requirements, with the minimum facilities, our graduates, they're doing wonderful job and they supply to the patient. But if you come to the big companies, prefabricated one, they're extremely expensive, and I don't think that anyone can afford
some
it.
people can, third world country definitely cannot afford that.
Yes,
But the pneumatic collar, I think that was very, that was really, really nice. I mean, it works really well and it's very appealing as well. There's no big deal about
yes.
that. But the Hero one and the Milwaukee one, all those ones were very, very huge. And I think there might be a little bit of problem in handling it as well. Do people
Well, you
encounter
see,
problems
the
handling it?
when the road accidents, they are traumatic cases. I mean, we are fitting those to the patients because they need it. Now, if you have complex fracture in the cervical spine, you need to have this kind of braces. There's no other option. Even the
There's no
doctor
other option.
operate easily without these braces.
At that
So,
time, it's not more important to look more pleasing or
yes,
something. It's more
yes,
important thing is to correct the problem that we already have. Exactly,
yes.
you're right. I think this is the end of our session, and I don't see any more comments. Probably because you've explained everything so well, and thank you so much for being with us.
My
And the
pleasure.
session was very informative, and I'm glad that we got to have a session with you. We plan on having more sessions like these with you as well. Thank you so much.
Thank you very much for your time and all viewers, and I hope that they got something out of my discussion. And I wish them all the best in this difficult time, and they take care of their health and near and dear ones.